Many thanks to the organising committee for this invitation to speak about multimodality imaging in the Paediatric Inflammatory Multisystem Syndrome temporally associated with SARS-CoV-2. In the spring of 2020, just as the first wave of adult COVID infections was subsiding, colleagues at the Evelina London reported for the first time in the journal Lancet a new and distinct clinical syndrome of multisystem inflammation, often presenting with cardiovascular impairment and, in some cases, profound shock. The shock syndrome was similar but distinct from septic shock or Kawasaki shock, and following this initial report, a national alert was issued and a case definition and initial treatment guidelines were published. This slide shows the weekly admission numbers with PIMS-TS for an 8-week period from mid-April 2020. Having so many seriously ill and unstable children admitted required an immediate response to ramp up clinical support and develop new ways of investigating and managing these young people. Adding complexity was the striking demographic of the affected cohort of young people. Unlike Kawasaki disease or even the age profile of our usual CHD inpatient population, many of whom are babies and infants, this PIMS group were older and larger, in some cases young men weighing 60 to 90 kilograms. This presented extra challenges in the imaging of cardiac function and coronary arteries. We did not yet fully understand the likely evolution of cardiac pathology, the risk of deterioration, or prognosis for recovery. So we needed to evaluate the imaging strategy to see what worked best, how often, and at what time. Apart from the older age and male preponderance, we also noted an overrepresentation of young people from Black, Asian, and minority ethnic backgrounds, as well as an association with social deprivation and being from a key worker family. In April and May 2020, we noted that PIMS, shown here in brown, arose 3 to 4 weeks after the peak in adult COVID admissions, shown in blue. With the inevitability of further waves, we needed to get ready and develop a sustainable imaging strategy. As adult cases began to surge again in December 2020, we knew more pediatric cases would follow, but the size of the second PIMS wave was unknown. Our MDT group responded using a novel combination of agile techniques borrowed from business with more familiar scientific methodology. We developed flexible, self-organizing teams, re-evaluated the pathway frequently, and prioritized the patient over any established practice. We stood up a separate cardiac imaging team, went across to 7-day working, and gained priority access to cardiac CT and MRI. This graph shows a timeline of service design interventions against patient numbers admitted with PIMS-TS from mid-April to early June 2020. Bars represent the number of children registered as inpatients on each day in PICU, shown in blue, and the children's ward, shown in orange. Call-out boxes at the top show the agile reconfiguration of clinical pathways, support infrastructure, and clinical staffing. So as expected and forecast, the second wave of adult COVID brought a larger second surge of pediatric PIMS patients, with monthly admissions peaking at 45 in February 2021. Fortunately, the earlier service reconfiguration meant that services were ready to manage and were stood up rapidly as the PIMS surge recurred. Our initial cardiac surveillance for PIMS-TS included daily echocardiography, as we had seen acute catastrophic collapse even after initial resuscitation. We also needed to understand better the role of CT and MRI, and in the initial cohort used both these modalities universally. The coronary pathology we saw on echo was different to Kawasaki's, and we needed to understand its extent and pattern. And the cardiac inflammation was also highly variable, and MRI had potential to define that better. Due to the novel nature of the condition, we performed a rapid but comprehensive evaluation of our multimodality approach. We also needed to reflect on what worked best at what time. 20 consecutive patients with a mean age of 10.5 years, presenting to the Evelina London, underwent serial echocardiography on admission, which represented day 5 of illness, and then again on a day coinciding with the worst cardiac function, day 7, and on the day of discharge, day 15. We performed cardiac CT to assess coronary anatomy with a median day of 15, and cardiac MRI to assess dysfunction with a median day of 20. The echo findings ranged from acute life-threatening thrombus, shown in the upper left, very poor systolic function, shown upper right, diffuse pancarditis with mitral regurgitation and pericardial effusion, shown lower right, and diffuse and ectatic coronary dilatation, but not discrete aneurysmal change, seen lower left. MRI strain was abnormal in many, and the ECGs were also abnormal in the majority, but showed a range of highly variable ECG changes. On admission, all patients displayed abnormal echo strain and abnormal tissue Doppler indices. Valvular regurgitation was seen in 75% and a small pericardial effusion in 10%. 3D ejection fraction was reduced in half the patients, and serial echocardiography demonstrated that 3D ejection fraction deteriorated before improving before discharge. Left main coronary artery dimensions were also significantly larger at discharge than on admission. Although LV function was abnormal on admission, this tended to get worse before improving, and our initial group, this was worse on day 7. This may reflect the treatment strategy, which has subsequently continuously evolved. CT showed uniform coronary dilatation, commonly affecting the left main coronary artery in 3/4. Cardiac MRI detected abnormal strain in all patients with global dysfunction, and myocardial edema in 50%, and in one patient, a subendocardial infarction. Cardiac CT, shown top left, was helpful in defining the extent of coronary involvement, particularly further out. The CT image shown is alongside the echo from the same patient. The MRI on the right shows a transmural infarction, which was fortunately rare in our patient cohort. So to summarize, systolic function is commonly impaired, but seen best using deformation imaging or 3D ejection fraction. Short to medium-term follow-up has shown good recovery in the majority. Coronary pathology was also common but largely self-limiting, at least macroscopically on echocardiography. And there is a role for functional stress testing, but the imaging and indications are still being developed. Finally, a few words on the large multi-center AEPC sponsored survey of PIMS-TS across Europe, which we recently published in Circulation. We received data from AEPC colleagues in 55 centres across 17 countries. We recorded cardiovascular and treatment data in 286 children. LV dysfunction was common, albeit measured by a variety of techniques. And at presentation, shock, arrhythmia, and coronary dilatation were comparable to single institution studies, unfortunately, mortality was low. The figures on the right show the wide distribution of cases across Europe. The age-gender pyramid is similar to our own institutional age-gender spread, and the number of patients against dates on the bottom shows the peak in late April, early May. So, over 2 PIM surges to date, we have iterated and learnt from our initial practice. Diagnosis is now rapid and treatment is started sooner. In our institution, MDT teleconferencing means many more children are managed locally rather than being transferred to our tertiary centre. Imaging protocols have been adapted to reflect our experience, the sustainability of the service, and the often remote location of the patient. Echo is performed at diagnosis, then less frequently if clinically stable, and always includes advanced functional imaging. CT is used in a targeted manner once coronary pathology is suspected, and MRI is indicated for patients with ischemia or prolonged LV dysfunction. So many thanks again for the opportunity to present, and I look forward to any questions.